Okay, so good afternoon, everyone. And today's topic is an interesting one. It is not a topic that is ordinarily required of the hospital administrators. However, because this particular aspect has come into the fifth edition of NABH standards, so therefore, this is one of the indicators that needs to be measured in the under the fifth edition, and this is the reason why the hospital administrators have got into this. The standardized mortality ratio based on the scoring systems in ICUs is essentially a part of clinical management of the patient, where a prognostic value or a prognostic score is calculated or computed based on various scoring systems. So today's session or this today's topic is to understand how this standardized mortality ratio is used for the purpose of measuring the performance of the intensive care units as well as for the quality improvement purposes. The idea is not to understand the scoring systems because this is a session of this kind for 30 minutes, 40 minutes. We will not be able to cover it properly and will not be able to do a good justice to the topic itself. Secondly, the use of scoring systems, for example, a GCS score, we all have heard Glasgow Coma Scale. So the GCS scoring system is something, the scoring systems like a GCS component scoring system is something that is used for clinical management of patients for quantifying the prognostic for the purpose of determining the prognosis of the patient as well as for multiple purposes for reassessments and similar functions. So the objective of today's session is to understand how this is implemented in the hospital because this is something which in my experience, I have realized that it is also not known to a lot of clinicians. And so therefore, as hospital administrators, our role essentially is to understand how this particular standardized mortality ratio works and how to help our clinician friends and colleagues in firstly, understanding that how it could be done, and secondly, implementing it in the hospital because the NABH accreditation system demands that this particular KPI, that is the key performance indicator, be calculated. The hospitals which are aspiring to acquire JCI accreditation or who are already JCI accredited, they need this essentially as a measure to assess the performance of their intensive care units. And it's a very good tool, takes care of lots of factors which ordinarily confound our assessment when we start measuring the performance of the intensive care units. One more aspect which we need to understand very well is that the performance of the intensive care unit is not the performance of the intensivist. Please understand that intensive care is a team effort. A role of nurse or nurses is as important, as crucial, as significant as the role of the intensivist, and so are a multitude of paramedical and the technical staff we have in the intensive care units. In addition to this team that is performing or working in the ICUs, we also have a significant role of the environment within which the care is delivered, especially from the infection control point of view, and also of various processes that are implemented in the intensive care units. We all know for the purpose of controlling and preventing the HAIs, that is the healthcare associated infections, there are multiple care bundles which are there for preventing infection and for the patient care. So we have seen this in several sessions also, and many of us are already aware that there are care bundles. So therefore, it is the people who are involved, that is the team. It is the structure or the environment of the ICU that is involved, and it is also the processes and the way they are implemented involved. So it is essentially a amalgam of these three components, and we will shortly see that this actually is in line with what the Avidis Donabedian talked about. It's called the Donabedian's triad. So the scheme of presentation of today's session will be like this. We will talk about why and how the ICU performance and quality measurement is important. We will look at some of the scoring systems which are there in the intensive care. Now, we are not going to the nitty-gritties of the scoring system because this is beyond the scope of today's session. But we will be talking about scoring systems, at least the ones which are in common use, and then we will talk about the standardized mortality ratio in intensive care as is required to be implemented. We will also look at the formula and the computation, the way the NABH accreditation system requires it, and the same way it can also be implemented for any other quality system, whether it is NQAS or whether it is JCI. Next, we will see the interpretation and the usage of it. And so let's come to the first of the point, which is evaluating the ICU performance and quality. So why do we need to evaluate the ICU performance and the quality of care inside the ICU? I think there are very obvious reasons to it. And one of them is that we intend to improve the patient care outcomes in the intensive care units. Our constraint remains that how do you compare that you have made an improvement, and therefore the role of scoring systems come. And needless to say that the outcomes of the intensive care units have a significant impact on the hospital's reputation. So better the outcomes, the better is the reputation. That is how it goes. And how we are able to assess the level of performance and then carry out some amount of investigation to figure out how and what are the factors that are not allowing us to deliver a level of performance that is necessary. So for this purpose, it is important to have the measurements which are comparable in nature. So for example, let's say there are two hospitals differently located in different places in the same city or in different cities. And we need to, or we want to compare the performance in order to benchmark our performance against that hospital, or even for the purpose of simple comparison as to how, where the performance is, where it stands. So the comparability will come only when we have used the same yardstick for comparison. So we need to use a validated scoring system. We need to use a scoring system that is peer accepted, so that both the ICUs use the same system, both the hospitals use the same system, and then only a comparison is possible. Now, suppose we were to use a measurement that is not, that cannot or does not lend itself to comparison. For example, it is a method that we have developed on our own, and we use it for our own hospital. Now, such a method obviously will have no value as far as inter-ICU comparison is concerned. But if we persist with that method of measurement, we can possibly see the performance of our own ICU, that single ICU, over a period of time. So if we repeat measurement, let's say we do one today and when we do one after a month, then it is possible to, over a period of time, see whether we are consistently performing or the performance is improving or it is going down. However, such method of having your own measurement is not very common. Two reasons. One, you need to firstly have that kind of academic wherewithal to develop a system, then have that kind of a large patient base to validate it, and therefore, what is the common practice is that hospitals use the established scoring systems, which are easy to use. Many of them are already the part of academic curriculum at the level of the master's level. So you have MD anesthesia, where these scores are covered. You have DM critical care, where these are taught. And they are also part of the standard textbooks of critical care and in mostly in anesthesia. So therefore, it is a good idea to use one of the established scoring system because they lend themselves to comparison. It allows you to compare your performance. The NABH accreditation system demands that you use one of the established scoring system. You can't use your own. The measurement, as I said, needs to be validated and needs to be peer accepted. So obviously, both of us need to agree that we will use this measurement, and then only it becomes comparable. Scoring systems, as I've said, these are used for the purpose of assessing or evaluating the performance of intensive care units. So the question comes, why should we do this at all? I mean, the fact that we are providing very uh, good care in the ICU and we are happy with it, then why should we measure the performance? The definition of quality is often based on conceptual donor obedience triad, and people who are in the administration and people who are associated with quality systems would have known that this is called donor obedience triad. And donor obedience triad has three things called structure, process, and outcomes. So what we discussed in the beginning of this session, that we need to look at the teams and the infrastructure, so that becomes the structure. Then we need to look at the processes that of care that are there, so we look at the processes, and obviously the outcome is considered when we talk about quality. Measurement parameters or measuring parameters like length of stay, the healthcare associated infections, and mortality are key part of measuring quality and overall ICU performance in as these reflect outcomes. So till the fourth edition of NABH standards, we have all been measuring various indicators that are connected with HAIs. So we talked about the COTI rates, that is the catheter-associated urinary tract infection rates. We talked about the SSI rates. We talked about the VAP rates. We talked about the CLABSI rates. So these are the rates we were already looking at, and these rates can be measured in just about every patient who fulfills the criteria for such things. For example, if you are assessing the COTI rates, the catheter-associated urinary tract infection, then you can include just about every patient in the hospital who has an indwelling urinary catheter, and 48 hours have passed from the time the catheter was put in situ. And therefore, every such patient becomes your denominator. And based on a definition as is given by the NSHN definitions, you pick up those patients out of this total patients who have the catheter, the ones who have the infection. So therefore, you get an infection rate, and this is always measured in terms of per 1,000 patient days. Per 1,000 catheter days. So we have been measuring the HAIs. We have also been measuring the length of stay. So long stay typically is associated with either a complex disease or their performance or a process issues. But a specific measure to evaluate the ICU performance so far was not included in the NABH accreditation standards. And in the fifth edition, this is the KPI, that is the key performance indicator, that has been included in the 34 indicators that are now mandated by the NABH. So that's the reason we are talking about it. And there is also a large amount of confusion in many places as to how to go about it. For two reasons, because using scoring systems is something which is not in common practice in the intensive care. This is the first limitation. And many times people are not aware as to how it is done. Standardized measurements enable comparison. I have already said enough about it. This comparison can be within the same hospital. So if you have multiple ICUs, then you could compare the performance of multiple ICUs. And because you're using a particular scoring system, and this scoring system is used in each of the ICUs in the same hospital, so you can compare the performance of even like the medical ICU versus the surgical ICU in terms of mortality. Please remember that it is always it's important to know that what is the parameter based on which the comparison is being made, and this is on the mortality. A sequential evaluation of a single ICU performance can also be done to highlight the progress in the quality of care. This is a method which you can use when you have when you implement a scoring system in your hospital, and obviously the first measurement will give you just the measurement, and it is of very little use. But if you repeat the measurement every month, then you will be able to see over a period of months how the performance is improving or it is static or it is going down. So standardized measurements give us that ability to do the comparison. Now, mortality rates by prognostic scoring systems is used to measure and compare the performance of ICUs. At least this is what the intent of standardized mortality ratio in the NABH standards when it says that you have this KPI for your hospital. Scoring systems are widely validated and present robust calibration that allows adequate measurement of mortality adjusted by the risk of death. So what we are doing is that we have a scoring system, and we'll see one such. We have a scoring system. This scoring system is calculating the risk of death. So it talks in terms of probability. And obviously, when we say probability, we say that if the score is, let us say, 35 out of 70 for Apache 2, then we say that the probability or the risk of death is 80%. So that's the interpretation. We will shortly see in one example as to how this scale or the score is interpreted. The interpretation of the score is different for different scoring system that is used. So we need to look at the interpretation of that specific scoring system that we are going to use in our own ICU. Okay, so this point we have already seen. Risk-adjusted scoring makes it less prone to the impact of case mix variation. Now, obviously, one can argue that in the ICU, you will have a variety of patients from variety of diagnosis, having variety of degree of severity, and may have different sets of comorbidities, or there may be one patient who has some comorbidity and the other one does not have comorbidity. So this risk adjustment, which is there, which is part of the scoring system, allows us to compare, to assess the risk and enable comparison even in such a case mix situations. So that's the benefit of using the scoring systems. We can also use severity adjusted scores. So instead of risk adjusted scores, that is a different ball game altogether. I am simply mentioning it here because there are such scoring systems available where the severity adjustment is done rather than the risk adjustment. The standardized mortality ratio is a measurement that only looks at the risk adjustment. So for the severity adjusted one, the example is a scoring system called SAPS SAPS 3. And these risk-adjusted scoring systems serve to evaluate the impact of new protocol or change in the staffing patterns or the organization changes. So risk-adjusted systems can be used when you have first made an assessment using a risk-adjusted scoring system, for example, Apache 2. And having done that, then you use one of these severity-adjusted and see how the internal changes in the ICU, whether the changes in the protocol or changes in the staffing, is having an impact on the performance of the ICUs. So now let's look at the scoring systems. In brief, I am not going to cover them. Neither it is necessary in a forum like this. We just need to know that such a thing exists. So scoring subjective score. So these some of these systems are they use subjective scores on its parameters, and these are established by a panel of experts who choose the variables and assign a weightage to each variable based on their personal opinion. So here you use like Apache 2 is a system where the scoring is based on, some of it is based on on a discrete number parameter, for example, the respiratory rate or the heart rate or the temperature, and there are some which are based on the clinical judgment of the treating doctor. So this obviously is a mix. Then we can have the objective scores where you have the variables are collected using the logistic regression modeling techniques. You do this by using the online calculation portals where these calculations can be done, and I'll share one such today. And the examples are Apache 3, SAPS 2, like that. So these are the scoring systems which use objective scoring variables or objective score variables. Now, we can also classify the scoring system based on the number of times they collect data. So like these scores, the Apache or the SAPS or the MPM, they collect data just once. So once the patient enters the ICU on the admission day number 1, so on the first day, the score is calculated, and that's the end of it. So at the time of admission, what is the predicted death is what is that is calculated. So you're calculating the risk on day 1 only, and that is the one that is used for the standardized mortality ratio. You could also use some of the other scoring systems which collect the data for 3 days, not for just 1 day. So some of the examples are organ dysfunction and infection system or scoring system, sequential organ failure assessment, that's abbreviated as SOFA. Then you have MODS, LOD, TRIOS, etc. These are the examples only to show that you can have a scoring system which relies on just one scoring system or just once scored, or you can have a system in which you have to do scoring for first 3 days of admission. So for example, a patient is admitted on, let's say, 1st of September. So you measure it for 1st September, 2nd September, and 3rd September. In the previous one, you do it just once on 1st of September. So that's only once. It is up to us to choose which one we use, depending on the complexity of our ICUs and the staffing and the clinicians available and the level of clinical support. For example, you only have a basic specialist doctor covering it, or you have a high-end tertiary care kind of a setup. So depending on what is the setup, you can choose a particular score. Eventually, we will see whichever score you use, the standardized mortality ratio is not dependent on which scoring system you use. So it is the scoring system that way is immaterial. The only important thing is that we must use the same scoring system when we are trying to compare it. So the common scoring systems which are in use in the ICUs are Apache 2, something known as SAPS2, then MODS, the multi-organ, like this. So I've just given a list. I think the most common can be the Glasgow Coma score, which is the commonest one. All of us are familiar with it, and it is used frequently. In many scoring systems, you will find that Glasgow Coma score is one of the is a subset of the other scoring system. So that way, you can also have a scoring system. It depends on how they are designed. All of these have been validated, tested internationally, and we could choose any one. But it is a good idea to use a common one because the other ICUs are also likely to use that common scoring system, and therefore it will lend itself to better comparison. Now, what is the characteristic of a scoring system? After all, how does it help? So a scoring system, as the name suggests, gives a numerical score. It gives you a number, and number lends itself to better comparison rather than having a qualitative, satisfactory, good, very good kind of a scale. Now, a grading system is also there. So you have a scoring system where each parameter or each variable is assigned a particular score depending on what it is. And then you have a grading system which actually interprets the total score that comes out from the score of each of the variables. And that is where the risk grading is assigned. For example, in the Apache 2 score, the minimum score is 0 and the maximum score can be 71. So if the score is 20, there is a certain meaning assigned to that total score I'm talking about. And if the score is 30, there is a certain meaning assigned to that. So that meaning is essentially the risk grading that is given. So typically it provides the severity of the disease, which tells you the prognosis and also the risk of death. And this is the point where we are interested in. The scoring systems predict death in terms of probability. None of the scoring system can ever give you that whether, in absolute terms. So this is relative, and therefore it gives you only the probability. So standardized mortality ratio uses survival as an outcome, which obviously is very easy to measure. Whether a person has survived or not is the easiest measurement that one can do. It reflects the efficacy of care provided by the ICU. So it reflects the ICU performance in that sense. And that is why it is included in the NABH accreditation system as a method to measure the performance of the intensive care Comparison of the standardized mortality ratio among ICUs are useful to compare performance. So any scoring system can be used. Choice depends on the severity, the scoring scale system, the index, or the model that must match the setting and application. I have just made this statement. I'm not going to explain too much about it, but just please understand that the different scoring systems, they are applicable to different settings. For example, there is a scoring system called prism, PRISM. It is applicable only to a pediatric setting. So like that, so depending on what setting you have, you must choose the correct scoring system and thereafter use it. So typically, this which scoring system to use should, it is ideal to leave it to the clinician's judgment, because they are the ones who are going to provide you the scores. So eventually, they should understand the setting where this particular scoring system can be, which one can be used. This is the example, or this is the formula which is given in the NABH KPIs book, that is the key performance indicators. So what it defines is like this: the standardized mortality ratio is the ratio of the observed or the actual mortality and the predicted mortality for a specified time period. It requires an estimate of predictive mortality rate using a scoring system. So we've talked about scoring system, and here also they have given examples as to which all are available. And there are many scoring systems. So there is a wide choice that is available here. The formula is the numerator has the actual deaths, which obviously is very easy to count, and the predicted death. We'll just cover this denominator in little more details. The multiplication factor is 100, so it gives you a percentage. If you don't use the multiplication factor, then it gives you a single number, which can be 1, where the numerator and the denominator are equal. So obviously when you have the equal dividing the equal, you get the result is 1. It can be less than 1 when the denominator is bigger, and it can be more than 1 when the numerator is higher. So this is the formula that is used. The standards require that you measure the standardized mortality ratio once a month. So it has to be done on a monthly basis. Even though if you're not accredited, and obviously if you're not under the mandate to measure it every month by the NABH, then you can also measure it once in 3 months' time. But once in a month is, I guess, optimum. So let's see how to use this. So we first talk about the numerator, and the numerator is the actual deaths in the given period. So if you have used 1 month, then obviously in 1 month, how many deaths have happened. This is easy to count, nothing really difficult about it. And it is always in whole number, as we can easily understand. The next is the denominator. Now, the denominator is the predicted mortality. That is the probability of death based on the scores obtained. So, which means that for a different scoring system, a different interpretation as is applicable to that scoring system has to be used. So, for example, Apache 2 scoring system, as I mentioned earlier, it has a minimum score 0 and the maximum score of 71. So any score which is 35 or more represents a predicted death mortality of 80%. And as the scores go higher, the predicted mortality increases. So this is one example. So based on this, you figure out the denominator, and then you compute the standardized mortality ratio. So if you multiply by 100, it becomes a percentage. If you don't multiply, then it gives you a number. And this is the interpretation. So if the numerator and the denominator, that is the expected mortality, the actual deaths and the predicted deaths are same, then you get a figure of 1, which means the mortality was as expected as far as that scoring system is concerned. If it is more than 1, then you have higher mortality than expected. And obviously, the moment we hear this, that the mortality was higher than expected, it means what? It means that the scores predicted that the mortality is a certain number. However, we ended up having a higher mortality. And what does it mean? It simply means that the ICU systems need to be looked at, because obviously there is a concern. There is something that is causing higher mortality than expected. And if it is less than 1, obviously when the numerator is lesser than the denominator, so therefore it is a better situation where our care in the intensive care units has made a difference in the outcome, and that is why the mortality is lower than expected. So lower than expected mortality reflects appropriate care delivery, and better outcomes are achieved as the result of care processes, or also as a result of the interaction of everything that we have discussed initially in the beginning of the presentation. So you have a team, you have a processes, you have the infrastructure, and the interaction of these three factors put together, as the Donavidian tribes put it, the better outcomes have been achieved. Now, what happens if the score is equal to 1 or higher than 1? Then obviously we have actual mortality which is either same or more than the predicted mortality. We need to look into the processes and the structures and the structures very, very carefully to find out where are the gaps, why is it happening, and we need to figure out by carrying out, let's say, a root cause analysis using multiple methods which are there, and find out why we have a mortality which is higher than expected and address that requirement. The NABH accreditation system would expect, and so is JCI and so is NQAS. The accreditation system or a quality system will expect that once you encounter a SMR of 1 or more than 1, then you carry out some investigation to find out the root causes and address those root causes. This is the reason why we, or this is the follow up that needs to be done. There is a website called the msdmanuals.com. Please look at this website. This is a website that gives you an online interface where you can calculate just about every scoring system that I have talked about. You just have to feed the parameters and it instantly gives you the number. Similarly, it gives you the score. Similarly, there are apps also available, and this website also works on mobile phone equally well. So you could use that and use it for calculating the scores, and depending on which scoring system you are using, you can calculate scores using this particular portal. It's a very helpful resource, and freely available, does not cost anything. I think it's quite good, and we should all be able to use it. And now I've come to the end of today's presentation, and of course we will take the questions as they come. This is in this for this session we will be providing this particular presentation. We'll also give you an article on scoring systems in the intensive care units. Very simple article I would say. Easy to understand. Please read it so that you get the overview of how the scoring systems are designed. It does not get into the nitty-gritty of each score. So in that sense, it is easy to assimilate. Similarly, there is another article on the similar lines, which talks about the scoring system. So this is what will be available as the downloads. Thank you very much. I have finished. I'll like to ask all of you to ask questions if there are any. Yes, Soumya madam, you want to ask a question?
Hello, sir.
Yes,
am I audible?
Yes, you are.
Good afternoon, sir. Thank you for the explanation. We had some confusion in our hospital about this, and it made things very clear. My question is that we have decided on the Apache 2 score.
Correct.
However, some of the clinicians are wondering if on the day of admission they decide on a Apache 2 score as per online calculation. Let's assume that it is coming to be early score like a 18 or a 20. However, the patient stays in the ICU for about a month or so, and it does unfortunately expire. So if you take the duration of the time that the patient has been in ICU, in the initial phase it might be 20, but by the end of it, due to various complications, the patient did expire despite the care, medical and nursing care. So in that case, wouldn't it kind of give a negative implication? So the clinician is asking, how is it a valid measure, and if that is the correct way to measure, or does it have to be remeasured at frequent intervals?
See, okay, so it's like this. Uh, you use a particular scoring system. Let's say you are using Apache 2. Now, Apache 2 scoring system is a scoring system which has been developed, over a period of time. It has been validated on large number of patients. It is a very old scoring system. I think it was first published in 1995.
Uh-huh.
So it is a scoring system which is established now. Now, the fact that the patient came to the ICU with a Apache 2 score of 18 and then he developed complications, whether the progression of disease or infection or anything else, I think score has nothing to do with this. It is the processes of the ICU which needs to be looked at. After all, just imagine a patient who I mean, okay, let's forget scoring system for a moment only. And we have a situation where a patient walks in for an elective procedure and does not walk out of the hospital. I mean,
Okay.
this is certainly not acceptable under any
Yes.
circumstances.
Yes.
So when you say that a patient came in with a Apache score of only 18 and over a period of time developed complications, I think we need to look at the care processes very carefully. Why the complications came about? Uh, the system of Apache 2 requires you to measure only once.
Okay, sir.
Okay. There are certain contingencies, and if you refer to those two articles that I will be providing as download, and it is not my specialization, so I don't want to dwell more than what I can handle.
Yes, sir.
But there are scoring systems which allow you to do a remeasurement at a
Yes.
certain point in the care. So this you could discuss internally among the critical care specialists and people who are working in the ICUs and figure out which scoring system suits you best. But to my mind, a system which is in common use is better to use because then only you can compare. I mean, there will be no comparison if you use such a unique scoring system, even though it is validated that it is used in few hospitals. I mean, how will you compare yourself? So that's the limitation of using such a scoring system. But I guess if you have somebody walking in with Apache score of 18 and then down the line on 15th day he develops things which he should not have developed, then we must look at the care processes in the hospital itself.
Sir, actually, the question was asked by someone who's in pain and palliative care. So I suppose maybe their way of looking at it was different. It was just
No,
a question
I,
that I was asked. I didn't
no,
know what to say.
no. So the answer is this: what I've told you. But please remember that subjecting ourselves to measurement
Uh-huh.
fundamentally is not easy.
Yes. It's
Okay,
difficult.
and especially if I have, let's say, 20 years or 25 years of professional standing in the line in which I work. Today, somebody walks up to me and says that, no, tomorrow onwards, I'm going to measure your performance. There are issues in this itself.
Yes.
So it has more to do with this factor rather than the scoring system itself.
Uh-huh.
So a lot of open communication within the hospital among the clinicians and unconditional guarantee that these scores will not go out of the hospital will help tremendously.
Okay. Okay, sir.
Okay,
Yes.
because this has very different kind of implications. I mean,
Yes, sir. I understand.
it's like clinical audit. I'm sure you understand that.
Yes,
So
sir.
in the clinical audit, we never identify clinicians or the doctors. We don't identify. Similarly, here also neither you should make an attempt to identify, nor you should use this data use this in a public forum or some such place, because then obviously nobody will like this measurement. And here the idea is to improve our performance and not to hide issues. So I think if you look at it from that perspective, it will become easier.
So actually, this leads to two more questions.
Yes,
One is slightly sensitive. Hope I hope it's okay to ask. Uh,
it is.
would it lead to medical legal implications if it is written in the patient's case sheet? If a
Uh,
score is written in the patient's
so,
case sheet?
okay, let me ask you the same thing from a different perspective. When the prognosis is not good, don't you inform the patient?
Yes, we do.
You not only inform, but you have a proper counseling system where patients' families' signatures are obtained.
Yes.
So you are already informing the patient,
Yes.
and this score is only confirming what you are informing. So what is the difference?
Okay. Okay, sir.
Isn't it?
Yes.
It is the score is doing what? It is predicting, giving you prognosis, and you are already informing the family about it. So I think there is no difference.
Okay. And does it matter if it is an open or a closed ICU? It does.
No, it doesn't matter.
It doesn't matter.
Doesn't matter. Yes, you asked another aspect of your previous question was to do with the medical legal implications. That is why the reason the clinical audits and such measurements like the standardized mortality ratios do not identify any patient and do not identify any doctor.
Okay. Okay,
Okay.
sir. So the
So
data should be
both,
blinded collection.
yes, this data has to be blinded, and that is why you can look at the systems. See, in the quality improvement, the idea is to not look at individuals, but look at only systems. So you do not identify any individual anywhere in your measurement process.
Okay, sir.
Okay, this is not the appraisal of particular clinicians. It is not the forecasting for a particular patient. It is about your care systems. It is about the teams, how they are working, and it is about the structure within which the care is being delivered.
Okay, sir.
Okay.
Okay.
So I
Thank
hope
you so
I've
much, sir.
answered. You will. Any more questions? We make an attempt to answer.
Thank you, Karan Rakesh. It was nice. In fact,
So
this
you're
was my
welcome,
second
sir.
session,
Sir.
and I think I got a feeling I missed a lot.
No, sir, nothing. No one missed a lot, sir. It's just that we need to start looking at things in a different manner. So that's all. But it is enlightening to interact, and it is also enlightening to discover new domains. So thank you very much. Thank you, sir, and thank you, everyone.